My name is Armin Rashidi. I'm an oncologist and a stem cell transplant physician. The patient population that I take care of and try to improve their outcomes through microbiome therapeutics are a group of individuals that are arguably among the most fragile and most immunocompromised patients in medicine. And these are patients with acute leukemia or other blood cancers who undergo allogeneic stem cell transplant from a donor. One problem that these patients encounter as a complication of transplant is something called acute graft versus host disease when the donor of stem cells, the stem cells attack the host and cause various problems, including liver damage, skin rash, and gastrointestinal damage, nausea, vomiting, diarrhea. It is a very detrimental condition that impairs quality of life, increases healthcare costs, adds to hospitalization length, and increases the risk of infection and can be fatal. So far, preventing this condition has been successful but not ideal. The medications used to prevent this complication are immunosuppressive medications, which add to the toxicity of transplant, and their efficacy is far from 100%. So the idea has been, can we find a non-immunosuppressive approach to prevent this condition, hopefully so that in future we can replace one or more of our immunosuppressive medications with something novel that's less toxic and hopefully more effective. And with this concept in mind, we considered the fact that the gut microbiome in patients who undergo transplantation is very heavily damaged, largely because of all the antibiotics that these patients get before and after transplant to prevent and treat infections, but also because of nutritional changes, poor enteral intake, and a few other factors that impact the microbiome. Um, Interestingly, these microbiome alterations have been associated with subsequent risk of acute graft versus host disease, likely because uh, the, uh, the abnormal altered microbiome may produce metabolites or other compounds that could impact the local gastrointestinal environment, microenvironment, but also change the immune reactivity of the allogeneic graft. So it was an obvious target for us to attack and try to fix these microbiome alterations by replacing the entire community of microbes that's been damaged with a healthy donor's gut microbiome, and this brought up to the use of fecal microbiota transplant (FMT) or intestinal microbiota transplantation (IMT). So in the first trial, we had, because these are very fragile patients, we first had to demonstrate safety and feasibility of FMT, and we showed it in a trial with 100 patients that were randomized between FMT and placebo. These are patients with acute leukemia and patients who underwent allogeneic stem cell transplant. We did this trial in the midst of the pandemic. It started during the pandemic, ended during the pandemic, and we did it in the University of Minnesota as a phase 2 randomized double-blinded single-center study. It was a very successful study. We demonstrated feasibility and safety of this approach with no high-grade or serious adverse reaction that could be attributed to the intervention. One interesting finding in that trial was that when the more effective FMT was in restoring a healthy microbiome after the initial damage, and we measured this by donor microbiota engraftment. So the higher this donor microbiota engraftment, the less appeared to be the incidence and probability of acute GVHD. And so this was a very intriguing observation because it led to the next trial, which we are now about to start. I then moved about a year and a half ago from University of Minnesota to Fred Hutch Cancer Center in Seattle, where I'm practicing and working on the same questions and seeing the same patients here at Fred Hutch. And this trial is now funded also with partial support from ACT, which we appreciate. And we are going to now specifically look at this question of whether FMT after allogeneic stem cell transplant, and FMT comes from a third party healthy donor, and we want to see if this approach compared to placebo can actually prevent acute graft versus host disease in a randomized single center trial. If this is successful, FMT can become the first non-immunosuppressive approach as an adjunct or a replacement for current immunosuppressive medications to prevent graft versus host disease. And I think if we can show this, this can have a very positive impact on the clinical outcome, quality of life, healthcare cost, and survival of patients who get a stem cell transplant. Thank you.